morning, everyone. Welcome to today's Knockout Opioid Abuse Day Learning Series webinar, Preventing Opioid Misuse and Addiction. Thank you for joining us. Today's webinar is designated for one AMA PRA Category 1 credit, one ANCC contact hour, one ACPE contact hour, one AAPA Category 1 CME credit, and one ADA CERP continuing education credit by the American Academy of CME, Inc. And for any pharmacists claiming credit, please note that your credit will be uploaded to CPE Monitor within the next 30 days. This webinar has been approved by NJOEMS for one EMT elective CEU. So welcome to our EMTs. The Partnership for a Drug for New Jersey is approved by the Board of Certification, Inc. to provide continuing education to athletic trainers. And this program is eligible for one maximum Category 1, Category A CEU. Faculty Holly Geyer discloses that she serves on the Speakers Bureau of Inviter PLC, and PA Planner Dean Barone discloses that he serves on the Speakers Bureau of Ethicon and Johnson & Johnson. And all other planners, faculty, and reviewers have no relevant financial relationships disclosed today. All relevant financial relationships have been mitigated. If you wish to claim CME CE credit, you must do so within 30 days from today's date. And after that time, we will no longer be able to issue you credit. Today's webinar is jointly provided by the Partnership for a Drug for New Jersey and the American Academy of CME, Inc., and is being held in collaboration with NJ Cares and the New Jersey Office of Alternative and Community Responses, and the New Jersey Office of the Attorney General and the Opioid Education Foundation of America. And I thank them all for their partnership, support, and collaboration on today's learning series activity and throughout this year-long series. I'm so pleased to welcome today's expert faculty. With us today, we have Dr. Holly Geyer, an associate professor of medicine and a consultant in the Division of Hospital Internal Medicine. She is dual board certified in internal medicine and addiction medicine and serves as physician lead on the opioid stewardship program at Mayo Clinic in Arizona, as well as the medical director for Mayo Clinic Arizona Occupational Health Services. So welcome, Dr. Geyer. And we also have Dr. Syra Jan, who is Vice President and Chief Pharmacy Officer of Horizon Blue Cross Blue Shield of New Jersey and Professor Emerita at Rutgers University's Ernest Mario School of Pharmacy. I'm so pleased to have this expert panel with us today. I think we're going to learn so much. And with no further ado, Dr. Geyer, I am going to turn this presentation over to you. So welcome.
Thank you so much. I'm so glad to be here today. We're going to get this slideshow up and going. Let me know if you have any problems seeing the images.
Looks great. Thank you.
Fantastic. Well, I am so excited to be presenting to this amazing audience, and I thank you for the invitation here. You're going to see there are approximately 1 billion slides that we're going to be going through. No sane person puts that in a 20-minute segment. There's a reason to the logic. I want this to be freeware, usability. We're going to have all of this available to every member of the audience to download and to use internally. All of my slides are available to all of you to reformat as needed, use all the content, and hopefully carry on this campaign, this message of making sure that the healthcare profession is now playing an active role in addressing the opioid epidemic. So without further ado, I want to jump in right now, talking a little bit about the epidemic itself. I don't know if you guys have been watching the TV shows out there. There's a bunch of them out there talking about the road to where we are today, one of multiple phases of our current opioid epidemic. And for those of you who go back to one of the originators of these TV series, there was one in the movie series or TV series Painkiller, where Richard Sackler, one of the heads of Purdue Pharmaceuticals, had made the comment in this TV series that I thought is probably one of the most insightful that I've heard in the industry. And he says, all of human behavior is comprised of two things: run from pain, run towards pleasure. Pain, pleasure, pain, pleasure. If we place ourselves right there between pain and pleasure, we'll never have to worry about money again. Think of opioids, right? One of the most powerful pain-relieving medications we've got on the market, capable in many patients of inducing a powerful euphoria, powerful pleasure. It is the drug that has tremendous potential to heal and tremendous potential to cause disease. If we look at where we are in America, the data shows that we use 80% of the world's pharmaceutical opioids. If you increase the illicit market into that, that number goes up. What percent of the world's population are we? 4.5. I'm no math major, but this seems a little discrepant to me. And it's costing us a fortune. This brand new data came out about a month ago. They looked back at 2023 and they said that if you combine all healthcare associated and non-healthcare associated costs to the US due to this epidemic, in 2023 alone, it cost us $2.7 trillion. Just to put that all in perspective, that same year, we took in $4.5 trillion in revenue, right? Almost 2/3 of our national budget of intake was spent directly back addressing our opioid epidemic. That's a lot of money. Is this sustainable? I can't see you, but you're probably shaking your heads. It's costing us lives. Right now, 2 out of every 5 adults knows someone who's died of an opioid overdose. I could sit here for an hour and give you names of people that I know in my industry who've worked with someone, who knows someone personally as a provider in their own families who's lost someone, much less you include all the patients. And the world, right, and America considers this to be one of our top public health threats. Opioids and fentanyl are consistently between 2023 and 2024 the top public health issue viewed by Americans. You can see it's somewhere between 24 to 26% in comparison to other big issues we're talking about, and that might be, taking up a lot of mainstream media attention. Cancer, obesity, mental health issues, all of that stuff seems to pale in comparison to the epidemic. It's still ongoing. So if I were the FDA, right, I would take this drug class and throw it out the window, right? Why do we have a drug with so much toxicity, so many problems to Americans? What benefits does it have? The reality is that they are right now the most common prescription drug class that we use for pain. They work. They help tremendously for moderate to severe pain, and they're one of the best tools in our arsenal to fight it. And the data shows overwhelmingly they're most likely to kill when they're used illicitly. Friends, I would make the argument today, opioids are not the enemy. Our misuse and our misunderstandings of them are. So if we think about the costs, opioids are costing us a fortune. In fact, I want you to pay attention to these bottom 2 numbers. If you take a patient in with an overdose and you discharge them out of the ER, it costs on average $500 to your healthcare system. If you admit them, $12,000. That's a lot of money. And for every 1 overdose, there's about 4.5 ER inpatient and outpatient visits that are associated with that activity. This is costing us a fortune. You look at addiction, the other major problem that we see with opioids, and the annual healthcare costs of people with opioid use disorder, also known as opioid addiction, are about 8 times higher than the average population. Those people also have 12 times more ER visits with an annual healthcare cost of about $20,000 per patient. By the way, the $20,000 number was a study done a few years ago. I believe it is very outdated, and I would love to see a more recent one. So how did we get here? If you guys have been watching those TV series, you already know these answers, right? We've had a long journey, and there was a lot of responsibility put here back on the major components to this, right? The medical community. We were taking articles written in the New England Journal of Medicine back in the 1980s that were 5 lines in length, retrospective studies that said, hey, listen, we look back at our healthcare institution, we found that only 12,000 patients that had gotten opioids when we screened them, down to about 4 patients had developed opioid addiction. And based on this, we think that the risk of using opioids pharmaceutically and ultimately developing addiction is low. That paper got recited more than 600 times. Now, I know there's a lot of clinicians in this room. Is that medical evidence? Is that a randomized controlled trial or a Cochrane analysis? That's a single viewpoint and a single institution retrospectively in a time and era when we weren't documenting opioid use disorder, right? Addiction. We took that and we ran with it. And then you add in all the other players, the Pain It's the Fifth Vital Sign campaign, CMS reimbursing us based on patient satisfaction for treating pain that may not even be there, but we were required to assess. And ultimately tying all of this back to pharmaceutical companies that were grossly under-supervised and ran rampant with campaigns and other issues that were antitrust and other things for the federal government blatantly illegal. And what you get is by 2012, the height of the opioid overprescribing crisis. That's not where we are now. In fact, if you look at the data between 2012, when the light bulb came on in the clinical community saying, holy moly, we've overdone this, time to rein ourselves back, we had a 50% drop over the next decade to about 2021 in the total number of prescriptions written. But what happened to overdoses, right? They've skyrocketed. They've gone up dramatically. And that's because when we started taking away the opioids, there were a whole lot of other things we didn't do for our patients. We weren't educating them. We weren't screening for risk factors for the development of addiction or for overdose. We didn't screen for addiction when we had these poor people on long-term opioid therapy, which, by the way, there is very little evidence for. We weren't referring for substance use treatment when we identified it. We didn't have naloxone, that opioid reversal medication, on the MAR for most patients. We didn't have policies or procedures to enable opioid stewardship principles in most healthcare institutions, and we were never advocating for the patients. What we ended up with was an opioid crisis of not just overprescribing, that's since tapered, but now opioid overdose. So I work at Mayo Clinic, and we had in 2017 started an internal review to see where we're at as an organization. And this great study came out by one of our surgeons up in Rochester. He looked at the opioid prescribing behaviors of 25 common elective procedures over a 2-year period. He found 93% of our patients got an opioid at discharge, and 75% of our patients got well over the recommended amount for the CDC. That's more than 200 oral morphine equivalents or more than 7 days. What's the funny thing about all this? A, it was very common procedures you might have had. I can guarantee most of your patients are getting. And number two, we decided to call them and figure out exactly what they were using. And out of 143 patients that we contacted, the average who had gotten 21 oxycodone pills had only used 7. They were using a third, right? And for those that did want refills, they said, listen, it was as easy as pie. We called them up, nobody screened us, we got our refill done. 89%, despite using a small amount of the amount given, were very satisfied with the pain regimen. We, as an organization, were prescribing too much. So then we said, well, what are you doing with all these leftover pills? Over here, friends, 69% were shoving them in medicine cabinets or on the countertop for their next do-it-yourself project at Lowe's, right? It's an impending disaster because this is where we had seen many individuals who had transitioned to opioid use disorder begin their journey. Leftover accessible pills by family members. And our prescribing has risks. When we look at these risks, if you give a person a 1-day opioid prescription, there's a 6% chance at 1 year they're going to be using that opioid. If you give them an 8-day prescription, that goes up to almost 14%. And burn this number into your mind. 30%, right? Or 30-day prescription, 30% chance of use of opioids at 1 year. This is chronic prescribing. If you authorize a second opioid prescription, you're going to double their risk for use at 1 year. Let's get this right from the beginning. So opioid stewardship, what is this? Well, what I'm advocating for today is what I believe every medical institution in the United States should have. Making sure these principles are in place. And the best way to foster it is by ensuring you have an opioid stewardship program, much like you have an infectious prevention and control program, or some of the other ones that might be in place in your institution. It's just using opioids in the right patient, via the right route, the right dose for the right indication, with the right medication for the right length of treatment, and employing the right screenings before you offer them, and the right referrals if your patient runs into problems. It is easier said than done, which is why only 23% of US healthcare systems have an opioid stewardship program in place. So it begs the question, why? We're in an opioid crisis. Our overdose rates are in the hundreds of thousands, although 2024, we may have seen a drop into the 90,000 range. Why? Well, because between 2016, when those CDC guidelines came out, and 2020, most states passed all these laws, opioid monitoring program reviews, the PDMP, prescribing limitations, naloxone prescribing. And so a study came out 3 years ago, and they looked at whether or not these had any full-time impact on whether patients were being treated differently. And they found the answer was no. There was a less than a 1% change in the number of patients that got an opioid prescription. There was less than a 2% change in the number of patients that got non-opioid treatment. And it had almost no impact on the days or supply or dose that was offered. The minimum is not enough, friends. So Mayo Clinic undertook the Road to Opioid Stewardship in 2017 based on external and internal evaluations of risk to our organization. And this is about the same time that we started seeing the Joint Commission and CMS embed requirements on this topic into their guidelines or their requirements. So I'm just in my last couple minutes here going to talk very high level about how to establish an opioid stewardship program of your own. One of the first things to do, initiate a team. I would recommend starting very broad. You're going to need providers, including a physician champion. And I would strongly recommend pairing that physician champion, either a background in addiction medicine and or addiction psychiatry and or someone that's very familiar with opioids, such as pain management, with someone in pharmacy as an administrator. It's a great team approach. Make sure you have nursing at the table, administration, IT, we embedded quality, your social work and case management, your legal team, and your government affair team. All of these members contributed significantly to our group. Next, you're going to need to get leadership buy-in for this. So what are you going to sell on this? Well, number one, compliance. Like I mentioned, the Joint Commission and CMS, plus multiple state laws and emerging federal laws are a great reason to say this has got to be a top priority for our institution. Patient safety, if you have not pulled benchmark data on how many of your patients are getting opioids, how many patients are presenting regularly with positive urine drug screens, overdoses, and how many patients you have on your service lines, inpatient and outpatient with opioid use disorder, it's time to do that. You can also look at patient satisfaction. When we integrated all of our opioid stewardship program principles, we noticed that we were able to maintain satisfaction while prescribing opioids less and improve our satisfaction in other domains of the practice, where now there were sensible approaches and an understanding of what you'll get from each division and department when it comes to opioid prescribing. And then costs. We've talked a little about those at the beginning, but there could be a lot of healthcare savings for your institution. If none of that works, we're in an epidemic, right? We're talking about the number one cause of death in adults under age 45 right now. This has got to be a priority. After you've done that, it's time to collect some metrics. We use Epic. More than half of the US healthcare system is on that EHR, which makes it much easier to standardize databases. What you're looking at here is our EHR opioid stewardship key metrics dashboard. And we look at a lot of things. The number of prescriptions greater than 90 morphine milliequivalents within the practice, how many have greater than 90 morphine milliequivalents with no naloxone, how many patients have opioid and co-prescribing of benzodiazepines, how many times patients have had their PDMP checks. And then we also break it down into chronic opioid monitoring plan, those on it for greater than 45 days, and then our acute prescribing world and our inpatient world. There are many ways to break this out, and you want to individualize it to your unique patient population. Cell numbers. I would recommend that you compare all of the things on this screen. I won't go into them in detail, but just keep in mind, you're going to want to look at these three major categories. Break it down into the pain management world and your compliance with national standards, the opioid use disorder management world. For what it's worth, many states are now integrating oversight of opioid use disorder management within healthcare institutions. Arizona just started it this last year. And then opioid safety. When you're writing prescriptions, how safe are those prescriptions for your patients? And are you ensuring that naloxone is on the chart? There's a resource we'll talk about here at the end, but a couple of years ago, the American Hospital Association initiated the AHA Stem the Tide Toolkit. It's a great resource that really goes over much of what we're talking about today on how to start an opioid stewardship program for yourself. And it goes in detail as to what needs to be in place, how to approach leadership, and then also talks about many of the benefits of that organized approach. Next thing you're going to want to do, build out your tools. I'm not going to lie. So this has been where 90% of our work for our opioid stewardship program has taken place because there's so much to tackle, right? You need to have policies, procedures on the use of opioids, but then you're going to want to individualize those to departments, to practices, to even specific procedures. And so I would strongly recommend that you have the right people at the table and then working group members to bring in. Our opioid stewardship program is the small team of individuals that I listed on that initial working group. And then we have what's called opioid liaisons, representatives from every single division and department across Mayo Clinic, Arizona, that is called in when necessary to represent their field and remains on a DL, for which we send out all updates on policies, procedures, or can reach out to when we find providers that seem to be out of line with current state or recommendations. You're also going to need staff education. Many external tools out there, but I would recommend broadly educating your staff on the status of the epidemic, pain management tools, and expectations of your opioid stewardship program. Patient education, we ended up with hundreds of forms and documents, patient education outlines, videos that I'll show you in just a second. You're going to need the IT solutions or the EMR solutions to help keep this moving forward. So they need to be at the table. Quality dashboards like we looked at. The forms you'll need, like a controlled substance agreement, are going to need to be developed. And then your referral network, if you don't have in-house pain management and or addiction management tools. Be sure to include alternative therapies there too. It's surprising when they're used adjunctively with opioids, there is benefit in the literature. So I know that our next speaker is going to go through some of these in more detail. What I would say is that you set up your opioid stewardship program to focus on these two fields: prevention of opioid-related complications and treatment of opioid-related complications. From a prevention standpoint, there's guidelines, multimodal pain management every single time an opioid prescription is written. I believe in 2025, there is no role for opioid monotherapy. There's no role. There's always an opportunity to add something else, either scheduled Tylenol, the NSAIDs, some of the novel agents coming out, those that work with central hypersensitization, and even alternative therapies like we talked about. Educate the heck out of your patients so they know what to look for and that they can feel open to talking about any complications they run into. For all patients on chronic opioid therapy, do opioid use disorder screening. There's a great tool called the Empower tool that came out from Stanford a couple of years ago. We use that as a two-step pre-screening for every patient on chronic therapy to see if we're picking up signs or symptoms of transition to opioid use disorder. Make sure you have access to programs in your area or develop one in-house to offer MOUD, and then make sure you're employing harm reduction practices as outlined by your institution and allowed by state. I won't go into these in detail. These are just some big concepts that we built in for our organization to help us really understand what are best practices when it comes to prescribing opioids. They are very much in line with both the 2016 and the 2022 CDC guidelines. So these are at your disposal if you want to review them in more detail. We integrated these like crazy into the practice. So we've got this program called Ask Mayo Expert, which is a great program that really allows us to work much like UpToDate does for many of you providers who use an external reference. It works by clicking on any of the topics that you can see here, plus more, and it brings you into an algorithm how to adhere to organizational standards for any medical issue. We've got these built in, as you can see here on the right, at a department-specific level as well. There's unique ways to prescribe opioids in gynecology as opposed to ophthalmology and orthopedic surgery. I would highly recommend, like I said, individualizing this. We educated our patients. We developed an opioid stewardship program website, and this is where all of our material is housed. It's great. People can click on that and get into the very specific areas of provider education or patient education or the forms that they need, quick and easy. Like I said, we've got many educational handouts and videos, and if you include the forms and documents and communication pieces and discussion guides, it ended up being in the hundreds. I would strongly recommend partnering with an organization that produces these tools and or forming your own. We trained our staff. We made sure that they were familiar with our opioid stewardship program website. We did grand rounds presentations. We went to division and department meetings. We used our opioid liaisons to communicate monthly at meetings. We tried every tool in the book that we could think of. We embedded all of this in Ask Mayo Expert. We created My Learning Tools, which is essentially a mandatory feed learning device that goes to every provider, every nursing staff, every pharmacy staff, saying, here are expectations in this particular area, like opioid stewardship. And over 15 minutes, they had to learn, how do we prescribe opioids and manage addiction at Mayo Clinic? Then we created courses. We've got, I think, 20 or 30 courses that now meet DEA requirements for that 8 hours of training. I had written a book, and that book is now 8 hours approved on ending the crisis, Mayo Clinic's Guide to Opioid Addiction and Safe Opioid Use. That's been downloaded and used for credit. We created an opioid resource center where providers and patients could go to learn more about it. And between all of these, I'm hoping that we're beginning to have an impact. But when it comes to the actual treatment of patients, I believe our biggest secret to success was actually embedding opioid use disorder treatment into primary care. It's so hard to get access, which is why somewhere between 10 to 20% of people that struggle with the disorder ever get treatment. We know that PCPs offer 1/5 of all opioids dispensed. So why not, if we're part of the problem, also be part of the solution? We've noticed that there were less deaths, fewer hospitalizations, and an increase in life expectancy when you look at the data. So we've done that at Mayo Clinic, and it's been pretty revolutionary. If none of this works, I think it's time to sell the need. We can't walk away from this as a healthcare community. We helped create it. We were right there at the beginning. We recognize addiction as a medical disorder. And because of that, not only do we prescribe part of the problem, we prescribe the treatments that get them out of it. Medications for opioid use disorder, or MOUD. The costs are crippling us as a healthcare system. And at the end of the day, we know people who've struggled with this. It's time to get proactive. These are our families, our friends, our patients. I think we may get one shot to get this right before we lose that loved one or that person that we're treating. So these are just some resources here. Like I mentioned, you're free to download the slide deck and use it liberally externally. I've got a book out there if you're interested in ending the crisis. It's got great patient information, and it's also been approved on our Mayo Clinic School of Professional Development website to download to meet your 8 hours of DEA training if needed. Tons of patient stories embedded in there too. This is the Stem the Tide Opioid Stewardship Measurement and Implementation Guide. They've also built a toolkit. You can go on AHA website. They have a whole page dedicated to the topic of opioids. Please do look at that if you're interested in the program. And then we've got an opioid resource center. It's just high level. It might be too generic for many of you who are more familiar with the epidemic, but if you know people who are new to the concept, it's got good information. So I'm going to pause here and hand it back over to the team.
Thanks so much, Dr. Geyer. Wow, what incredible information that you shared. Thank you so much. We appreciate that you're going to share your slides, as we'll share Dr. Jan's slides as well, who's coming up. So I know there's some questions in the chat about that, and we'll just come back for some question and answer, but after Dr. Jan's presentation. So, Dr. Jan, welcome.
Thank you, Angela, and thank you, Dr. Gaia, for a fabulous presentation. A lot of information. So being a second speaker, it's always an advantage and a disadvantage. But I'll focus on the advantage because I think she covered a breadth of information. And the good thing is that all of that information is available for all of you as an audience to leverage and learn from and utilize. I think that's the most important thing that we need to consider about how we really manage this condition. So if you can flip to the next slide. What I'll focus on building on Dr. Gaia's presentation is really recognize the relationship between appropriate prescribing of opioids and the prevention, and what are the levers that we need to utilize to be in that space. Identify the key risk factors and do that from a predictive perspective versus in a reactive phase that we have been doing over the years. The third component that I would want to focus on is how do we mobilize community stakeholders, because an important component to and a stakeholder in this is the community partners that are there, the members, the aspect of education and reaching out through multiple touch points, right? If we go to the next slide, we'll see that if you look at opioid crisis, it has come into three phases. The first phase that Dr. Greyer prescribed very eloquently was the prescription phase, which was started in 1990. And, I started my career in 1995, and it's very interesting that opioid crisis became crisis, but I distinctly remember managing opioid the day I started in a payer environment at Horizon. So opioid prescribing and management has been something pretty common. What has changed from an opioid crisis perspective, that the first phase was the prescription. The second phase, we were seeing overdoses deaths due to heroin. So there are street products that are available that contributed. And then the third phase that we shifted on is the lacing of synthetic opioids, particularly fentanyl. And now we are in a phase where the methamphetamines or stimulants are coming into play. So the combination product, the lacing of the products, especially Xanax and opioids with other or counterfeit products, even if you go and buy them from the street. So just let's keep that in mind, that the phases are changing and we have to respond appropriately and accordingly how to manage those pieces. So if we go to the next slide, this is basically, as she indicated, there's a decrease in opioid utilization and opioid prescribing by multiple programs that we have seen put in place. But as we see in the healthcare community, that the problem is not just limited to the prescription, but the problem has expanded now to the street products. The good aspect is that the naloxone use has increased, but depending on what the overdose is, naloxone may or may not be valuable in doing the intervention. So I'll pivot now into the contributing factors, which is the next slide. And I'm not going to spend too much time on that because Dr. Grier spent a lot of time opioid prescribing. Remember the days when we were prescribing thinking that it is under treatment of opioid. And that's a fine line which still exists right now to say patients who need it should get it, but we need to make sure that they get the appropriate amount. And then there is opportunities for them, practical opportunities, education to say, how do you dispose of these medications, and don't take more than that. That goes from provider and the member perspective. Opioid risks are not understood as well. So based on the prescribing, based on the consumption, that is an area of education. And now we know that the main driver of this opioid crisis is illicit fentanyl, the lacing of products, counterfeit products, and labs are making these tablets. And then the other contributing factor is social media, right? That did not exist years ago, but now with the social media, the younger people who are on the social media, or the accessibility has increased very differently. Now, an opioid can be delivered to a dorm's room, and then there's a survey after that to say, hey, how good was the product that you got? So the mentality, the access, the social media brings us into a very different approach of managing opioid epidemic. And I think that is an important concept as clinicians, non-clinicians that are dealing with this as family members. If we have, first-hand experience, need to start thinking about that. The next slide goes through the CDC guideline. Again, very not has changed much in the sense that, yes, you need to use non-pharmacological, and then if you have to prescribe an opioid, limit the units and go from there. But from a payer perspective, I think what is very critical, if you go into the next slide, is understanding the risk and monitoring of these opioids. So utilizing the databases and understanding that what are the prescribing behaviors, who's getting these medications, what is the underlying condition that can really predispose a patient to really abuse this product. And many of these points have been touched by Dr. Grier in terms of having a treatment plan. And think about it. One thing that I would say is that a lot of pain management specialists do have those resources in-house of behavioral health screening, but primary care does not. So when a patient walks in a pain management specialist facility, the first thing they do is have the behavioral health screening. A primary care does not have that resource. So for them to think about that is critical, especially when you're prescribing chronically. PDMP has been a great tool that has been available in different states, and leveraging that tool is critical to really understand not only drugs, but cash paying and prescription drugs, all those pieces. Understanding and educating the providers on random urine screening, especially the primary care, is very critical. Staged urine screening really does not benefit because there are a lot of things that can happen that can really not give you the good results. Reviewing patients' medical records for discrepancies. If a patient walks into the ER, understanding he might be going to 10 ERs in one day, what is from an EMR perspective, utilization patterns. So from a payer perspective, literally understanding the data along with the PDMP enables us to do a lot of proactive predictive modeling and understand that what is the pattern that this patient is exhibiting that could potentially lead to a risky behavior. And screening tools, whether they are at the physician level, informally at the retail level, when you see people paying cash and people, taking large quantities, and from a payer perspective, looking at the data from different utilization areas really helps us to manage this. I think it's very important when we are assessing risk is to have the collaboration between the behavioral health as as well as the specialists. And even in this world, we live in a very siloed groups where a specialist could be prescribing a drug for rheumatoid arthritis and managing the patient, and the patient is not on the right drug or is not getting the right treatment. And the pain management specialist or primary care is in treating the dose because the patient has a drug. Talking among those specialists is critical to make sure that the rheumatologist knows that the pain is not managed, is it that he has to change the rheumatology drug versus increasing the pain management. And you'll be surprised how many times we broker those conversations, which I think should be part of any stewardship program, should be part of a protocol that an EMR has to really make sure that we are connecting the dots between the prescribers. If we go to the next slide, it basically talks about the value that PDMP brings, right? And layering this information and understanding cash paying customers as well as dispensing opioids or talking of even providers writing opioids. Not looking at this is a big miss. So, and I know we've gone a lot of detail on this, so I'll skip over to because I want to leave some time for Q&A. Again, the next slide goes into the details of what a PDMP profile looks like, right? When you review a patient profile, and if we have a lot of pharmacists and physicians, I think you're pretty much familiar with what the PDMP profile looks like. So we'll fast track and go to the next slide, which I think is important for all of us to understand. If we can move to the next slide, is that it is not a solution that is going to come from one organization. We have to work with different stakeholders, education, treatment, community, non-opioid products that are available, supportive care, other acupuncture, different things that can help us. Education has to be focused a lot on prevention. Especially, I want to re-emphasize on the fact that we are in a very different world because they are social media. So when a kid puts a post on to say, hey, I was high on this product, it was really good, everybody is looking at an individual who survived as having a great time. So the misnomer of that you may die with it is a very different thing to post, and that's why it can be positive and negative. Treatment and recovery and community outreach is critical because community outreach really helps us in leveraging the DEA office, the community ambassadors that are out there, the individuals that are experiencing it and are now going to be a ambassador or a teacher to a young teenager. So with that, if I go into the next slide, that gives you what every payer and hospital or medical provider, a pharmacist, a manufacturer, behavioral health, workplace support systems is an integrated team that has to be working together to address this issue. And it is not limited to opioid. The stimulants are now a part, and a combination use is a part. Legalizing marijuana is a part where people go from one level to the other and think that it is safe in many ways. Early detection is critical. So when somebody starts an acute medication, how do we identify that through the data and help reducing the conversion from an acute to chronic is a key initiative that really helps in prevention of chronic utilization. Changing behaviors in prescribing, identifying behaviors of that even the providers may not be aware of for their members and not understand that how their practice is being penetrating. Somebody's driving 100 miles to go to a provider, which the provider may not even know, to say, oh, he's easy to write opioids, let's do that, is a process that people can identify and communicate with that provider, educating them the information. So PDMP is one level of what the actual is happening, but also doing predictive modeling and providing that data in terms of that specific physician prescribing behavior in aggregate versus only by physician level is a very important aspect of identification and education. And if you go to the next slide, it basically summarizes the care team, or I'm sorry, I'm skipping this. Again, this is the different programs that the payers have in place and we have in place in the hospital systems to really manage these patients for earlier detection. The next slide goes into the opioid abuse toolkit. And I'm going to take up an offer from Dr. Grez because I think the stewardship, how to start up a stewardship program is missing in our opioid abuse toolkit. And the reason this abuse toolkit has been a big resource that was developed at Rutgers in 2017 is, first of all, we provide it for free. There's a lot of very practical information that's housing in this toolkit. And the reason I say that is it's not developed by some corporate individuals or standard big government organizations. Lot of information that is in this is developed by the students at Rutgers, as well as young individuals in the community and community collaborators who are seeing this firsthand. So that information can relate to the information of the end user. There are pieces in there that is for community provider as well as the systems. And again, it's free. The PowerPoints are free. You can go and utilize them, customize them. We just request you don't change the content, but it is updated literally every other month. And the most recent thing was hyperemesis syndrome on marijuana. So there are things that are happening in our community that we get information from, and we create decks to respond to that. So when the school presentations were being done, vaping and how to educate the kids on vaping was brought up. And this will be a link that will be posted. And it is, like I said, you can go online and you can be, and we always also request that you send us topics that you may not find in this opioid abuse toolkit and other resources that you want us to develop, and we will develop it and provide it and update it on the Rutgers website, which will be available at Horizon website, but also at Rutgers toolkit. So I think what I would want to do is um, end here so that we can have more Q&A and answer your specific questions based on our presentations.
Thanks, Dr. Jan. Appreciate the information that you shared, and I think it's so important that we get some questions from our attendees. So please go ahead and put those into the chat. And Dr. Jen, can you just talk a little bit about how a community pharmacy can begin to develop a program where they have communication with their patients, or to talk to them about opioids and other medicines that they need to be aware of?
Yeah, and I think that's a great question, Angela. For community pharmacists, I think they can play such a significant role because think about it, they are the people who the patient sees the most. Patient sees community pharmacists a lot more than even a provider, right? And uh, I have spoken to a lot of community pharmacists, and when I have started investigating this years ago, and one thing that really always stuck in my mind is when patient comes in and are paying cash for opioids, right? They are not going through the prescription benefit plan or something. That's a red flag. And then they have that credibility in most cases and relationship with those patients to have that discussion, understand, and there's so much data, even print out a flyer and say, who is this prescription for, and do you really understand the consequences, and detailing them, right? I don't know if that detailing is always happening, because think about it, we go in the pharmacy, we pick up a prescription, we sign, and half the time, more than half the time, people don't know what they're signing. They're basically saying, I don't need counseling. So when you are dispensing opioids, I think it's really worth the effort to do that. If somebody's coming and paying cash and they have a pharmacy benefit through their insurer, question them and try to help them out, right? I think there are a lot of opportunities in looking, and they look at the PDMP. They cannot really dispense anything without looking at the PDMP, which is a big opportunity for pharmacists to intervene.
No, thank you. And just for our attendees, I know the poll just launched, so if you could take a minute to complete that, we would appreciate it. Dr. Geyer, we'll jump over to you quickly. Could you speak about the role of patient partners on the opioid stewardship team building that you discussed? Could you discuss that a little bit further?
Absolutely. I think a lot of times when we form working groups or introduce new concepts, it's not uncommon to integrate the patient opinion or a family opinion into those initial working groups. We had a lot of discussion about that at Mayo Clinic, and we ultimately elected to use survey results and our Joint Commission patient satisfaction results as surrogate of our interventions. There's a lot of predispositions, right? Preconceptions, shall we say, patients hold on the topic of opioids. Not a day goes by in my practice when someone who is chronically on opioids, clearly demonstrating behaviors consistent with opioid use disorder, says it's all pain related. Why would you take away my opioids? Why would you pull back on these? Don't you know I need these? And I believe them, right? There is something that takes place cerebrally, and that's a whole new topic on the neurobiology of addiction that we could go through, that says, I need this drug and I'm using it for pain management. We didn't want to alter our approach with best available standards based on a disease that might drive the conversation a direction we knew it couldn't go. So I would say for community members and for patient education components, yes, we get valuable feedback by introducing these concepts to our patients and asking them, what do you think? What would you change? What do you have more questions on? In building out our initial opioid stewardship program, we elected not to take that approach.
All right, thanks. And I know, Dr. Jen, I saw you agreeing with so many of those points. And when you were creating your toolkit, I know you're creating the toolkit for those who are professionals as well as people within the field who are just involved. But I know we have a lot of school nurses on with us and other people who are in the community. Can you speak about, that role, the role of people who have lived experience?
Yeah, and I think my approach was slightly different because we are based, our corporate office is based in Newark. And even before that, we were working with a lot of community, young kids, teenagers who were struggling with opioid abuse, right? And when the whole goal for this toolkit when it started was, are we creating materials and education and the right venues to educate this young population? I mean, are we creating? So we created posters and they were created, but I actually did not use my communication department at that point. We actually used the kids. Rutgers students, younger kids from the street to say, hey, if you are in the train or if you're seeing an Instagram, what would be an impactful message for you? What will resonate with you to say this is not a right thing to do, or you should seek help, you should seek a different help? And they created it, and we still have those posters, we still have those messages that resonated with them. So I think one thing we learned and we did differently in this toolkit was we went out to schools, educated the younger population. We wanted to start very young and understand what are they seeing. And it was very interesting the feedback we got from the young kids on what their struggles were and what they were facing on day-to-day basis really helped us learn and customize the materials for education that we were sending out. And I'll give you a quick example that we were talking to these kids who we would bring every month from with the social worker in at Horizon, and we would just talk, okay, what is, and one of the kid still I remember would say to us is like, I am struggling. Both my parents are addicts. I walk out of the street 2 blocks away. I have friends who are saying, hey, listen, this is fine. Why don't you try it? I don't have food in the house, and I'm trying to fight and help my friends not get addicted. So, this is something that as providers, as healthcare individuals, we need to understand that everybody is at a different time level and we need to meet them there and we need to help them there, right? We have a lot of adults in nursing homes who have been over time addicted, right? They are on high doses of opioid, and I know Dr. Geyer sees them most of the time to say, how do you tell an 85-year-old you don't need this opioid medication for your knee pain? So we need to think realistically, but I think my biggest approach is how do we prevent this and educate our younger population? Because if they feel that it is safe, they feel that it is safe to go out and get street drugs, it is a big problem that we are facing right now.
No, absolutely. And you both really spoke about the importance of educating your patients, educating the community, making sure people are aware. So I'm going to go to both of you on this question because you both talked about it. But Dr. Guy, I'll go to you first, and then Dr. Jan after. But you both talked about educating your patients about alternatives. You talked about educating your patients about things that they may not know when they're getting a prescription or when you're seeing them. Dr. Geyer, can you talk about what that means to you, what that means?
Yeah, it's a great question. The concept of education is to put us all on the same page, to make sure that on the topic of opioids, the patients understand it's us and them versus the toxicity of the drugs, not us versus them. And I will say I made a personal mistake very early on in this epidemic by not having developed education tools to the patients that changes were coming at all on behalf of our organization. We started implementing them, and the phone calls and the email. I'm getting PTSD talking out loud about this. The reality is that once we developed a document that said, you're going to see changes coming on behalf of our organization, there's a reason for it. And we started outlining the data. We got thank you messages. We got appreciation comments from our patient because we were all on the same page. That does need to take place holistically on every topic you touch on in the world of opioids. Why you're making changes to ensure adjunctive medications are added on with opioids to reduce the toxicities, to reduce their dependency on it. Why you offer shorter series. Why you're making referrals to other parts of the organization that do procedures to limit exposure to oral therapies. I found value to it. Not everybody learns the same way. We've got a process now to embed patient education videos when you first get hospitalized on expectations in the hospital for pain management, safe use of opioids, and what to do with opioids on discharge. They also get pamphlets on this too. I think the more encompassing you can be on this topic, and that includes having these direct conversations with those patients, the more bang you're going to get for your buck for investment.
Yeah,
Thank you,
and I
Dr.
think the only
Dyer.
thing go ahead.
Dr. Jen, would you like to continue on and answer that question?
Sure, I was just going to add to that that that's exactly what it is. And the education is not, like you said, limited to the member, but also to the provider, right? And one very impactful education is really showing that specific provider aggregate behavior, which is like a light bulb to that behavior to say, oh, I didn't realize that I was prescribing to the whole family, or this family was commuting 100 miles to come to me. So education can be at different levels that can really impact, right? Some of it could be identifying multiple polypharmacies. Some of that education could be really utilizing the data and educating, but I think we need to partner together, right? So now we have connectivity even at the ER. So if a patient goes from one ER to the other ER, it can be captured. So utilizing those pieces of information and translating that into prescribing appropriately really helps, because people are going to game the system. Providers sometimes intentionally or unintentionally are going to be, we cannot exclude at some level, some of the providers who may be doing it intentionally and educate the ones who are not doing unintentionally, but bringing them at the radar is going to be very critical.
Great, thank you, Dr. Jan. And I apologize, we had some technical difficulties, so I'll just finish up the Q&A here for Angela. We have just about a minute or two left, so again, just want to thank Dr. Geyer, both you and Dr. Jan. And at this point, we'll just close off with some final thoughts, key takeaways that we can leave our audience with today. Dr. Geyer, would you like to go first?
Yes. We are still in crisis mode. I know we've all seen the improvements in 2024. I hope these continue. There's no guarantee. I will say that what we're seeing are reductions in death. That is not a direct one-to-one correlation in reductions in addiction. And if we go back to 2013, where 80% of all people had moved over to heroin having started on a prescription, it still shows the tremendous value of us getting this right from the beginning. If you do not have an opioid stewardship program, I strongly encourage you to download those AHA resources and go public with your institution with it. I run this with a colleague. We get 10% category time, which means 10% of my time seeing patients is taken away to do this topic. I would imagine your institution can afford that. You pair a person with a pharmacist, and I think you've got a winning team to get one of these up and running.
I think my key message is that all of us can contribute. You see the passion in Dr. Geyer. I mean, that's so obvious in her presentation. We all can contribute to this issue, and it is going to not go away in the near future. But what we can help do is to really understand where it is morphing to. So looking at the stimulant utilization, looking at the utilization outside the prescription, looking at what we can do to impact, further increase, developing stewardships, developing at a retail level, different initiatives targeting, developing database, working with PDMP, payer perspective, community perspective is the collaboration model that we will need to have, and have the right stakeholders to work together. I think that is really critical for this issue to really be managed more effectively.
All right, I want to thank both of you, and Apologize for losing my 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 Zoom service for a minute. And thanks, Matt, for jumping in for me. Thank you so much, both of you. Excellent presentations, excellent questions that you took, and really appreciate both of you and your time on this. I want to also thank all of our attendees for joining us. It's so important that we continue to learn new aspects, new strategies. And I think both of our expert speakers spoke about that today. So thank you for all of you. We're at the end of our time, so we are going to end, but I hope that you can join us next month. It's just in 2 weeks, March 13th. It seems that February ended so quickly, and but join us for community strategies to fight opioid addiction on Thursday, March 13th. So thank you again to all of our attendees, and thank you to our experts, and wishing everyone a great day. Thanks.
Thank you.